This educational presentation is on the use of the NitroNox field unit. This device is in the scope of practice for advanced EMTs and paramedics, but all levels of providers at UVA are required to complete the educational program and be verified on the appropriate competencies. Nitrous oxide is a drug. More specifically, it's a medical gas which is used as an analgesic. Advantages of nitrous oxide for reducing pain are: it is relatively safe and there aren't many serious side effects. It is effective in most patients, and the onset of effect is fast acting. The method of delivery is easy for the provider and the patient. It doesn't require an IV access or IM or intranasal administration. The NitroNox kit is relatively compact to carry to the patient. The effect of NitroNox is fairly short, so if a patient gets too much, it subsides a very short time after removing the mask. The way nitrous oxide is delivered in the field is a 50% mix of nitrous and 50% oxygen. It thus has a fail-safe mechanism to avoid hypoxia. A fairly common term for nitrous oxide is laughing gas. Although I don't think it actually makes folks laugh, it can make them a little bit giddy. So when we're telling a patient what it is that we're going to do for them, using the term laughing gas may help. Its intended use is for mild sedation and analgesia. The gas is colorless, odorless, and heavier than air. It's non-explosive and non-flammable. One of the properties of nitrous oxide in the body is that it readily and rapidly diffuses through the membranes, including the blood-brain barrier. Again, it has a rapid onset of effect and a rapid cessation of the effect once inhalation is stopped. What does it do? It kind of dissociates the patient from the pain. They may perceive the pain as less than it was, or they may just not care as much. Like a lot of things in medicine, still, it's not fully understood, but it probably activates the opioid receptor system a bit, which can physically reduce the pain. The gas diffuses through the tissues more readily than other substances in the body, like oxygen and CO2. That's why we always have to employ a blending device with a safety shutoff in case the oxygen runs out. One of the main things we watch out for is conditions where there may be an abnormal collection of air, particularly air under pressure. The problem is that the gas may diffuse into these areas, increasing the collection of air under pressure. Patients with COPD may have blebs, although COPD itself is not a contraindication, just a caution. A pneumothorax could easily get bigger by the diffusion of nitrous oxide into the area, so that's a legitimate concern. So is bowel distension. So we have to use critical thinking when we have a patient with abdominal pain. Is this bowel distension or some other mechanism of the abdominal pain? So what are the indications? Well, severe pain. I would say typically someone categorizing their pain as a 7 or higher. So yes, you have to ask the 0 to 10 pain question. So we're looking at pain from fractures, pain from musculoskeletal trauma, severe back pain, pain from burns, pain from kidney stones. Now these are the indications that we're starting with at Upper Valley Ambulance. Once we've gotten used to the drug, we'll expand the indications a little bit more to things like undifferentiated abdominal pain, acute urinary retention, and importantly, chest pain due to expected cardiac origin. We won't have that on our standing orders to start with. So like all drugs, we have indications and we have contraindications. So the contraindications for nitrous oxide use are significantly altered level of consciousness, head trauma, chest injuries, intoxication, significant maxillofacial trauma, psych issues. We're going to use caution in patients with pre-existing severe respiratory disease. It's not an absolute contraindication, but something we want to be careful about. OB patients, bowel obstruction or abdominal trauma, and inner ear pain because that could be an air collection issue. Side effects of nitrous oxide. Well, they're usually mild and they go away quickly when the gas administration is stopped. So we have dizziness, headache, confusion may happen, apnea. Okay, apnea is not a mild side effect, but it is a pretty infrequent thing if it is even real. Cyanosis, nausea, hypotension, so you need to monitor vitals frequently. And understand if the ventilation fan is not on high, the ambulance crew may start feeling the effects. So the window between the front and back should be closed. They certainly don't want the driver getting kind of giddy. And it may be smart to only use the device before you put the patient into the ambulance to settle them down, but not use a nitrous oxide unit in the ambulance at all. Something to think about. Once you stop the NitroNox use, the oxygen saturation may go down transiently since you're taking away a pretty concentrated oxygen source. And you need to continually monitor with pulse oximetry. And I would suggest monitoring with end-tidal CO2 would be pretty smart as well. Next we have hazards. And I have a question mark on there because I'm not sure that there are actual hazards here applicable to us. You should, however, be aware that the government tells us that occupational exposure to nitrous oxide can be harmful. However, that references individuals that are exposed to it frequently in the course of their profession, such as dentists, dental hygienists, anesthesiologists, and such. It also says that in an unscavenged system, that would mean that we would need to have more than 5 hours of exposure per week to consider it being hazardous. Now, we do not have the ability to employ a scavenger system in our trucks, so you need to always be aware of the need for a well-ventilated environment. Now, this includes the patient's home, which is probably pretty well ventilated, and outside the ambulance. But again, we may need to limit or avoid the use of nitrous oxide while in transport. It's a judgment call that you're going to have to make. Nitrous oxide is only self-administered. Let me emphasize that again. It is only self-administered to a patient who is awake, alert, and cooperative, who can understand what you're telling them. We cannot hold the mask for them, nor can a parent hold a mask for a child. You got to remember, if the patient has too high exposure to the gas, they'll experience a diminished LOC, and then they'll drop the mask from their face, which is what we want to happen. For someone other than the patient to hold the mask in place could cause disastrous consequences like hypoxic brain injury or death and the end of your career. So what you want to do is you want to instruct the patient to breathe deeply through the mask to reduce their pain. The patient controls how much they get to decrease their pain. During this time, you must continue to evaluate them, ask them about their current pain scale, and you have to monitor their vital signs. The NitroNox field unit comes in a handy-dandy carrying case which contains one nitrous oxide cylinder, which is connected to the blending unit, which mixes the nitrous with the external oxygen supply, whether you're using a portable oxygen or the onboard O2 tank. Contains the oxygen line and snap-on connector, and it contains the inhalation hose, the valve, and the mask. Now remember, the gas is only delivered when the patient inhales. If the patient fails to make a good mask seal and take a deep enough breath, they may not get any gas, thus no pain relief. If that happens, you're going to need to coach them better. The safety system is set up that if the oxygen tank runs out, there's an audible alarm and the unit shuts down. Thus, the patient does not breathe nitrous without oxygen, which would likely result in their demise. So you should appreciate the safety system. If the nitrous runs out, the audible alarm will sound and the unit will only deliver straight oxygen. That's not all that helpful at relieving pain, so you're going to want to switch out a new nitrous oxide tank fairly quickly. The NitroNox unit likes normal temperatures. It doesn't like the cold, so understand that if you need to take it out to a scene in colder weather, You need to try and keep it warm as long as possible, or it becomes less effective at moderating pain. And it is really important to remember to keep the unit upright at all times, or again, it loses effectiveness. These are the protocols for the use of nitrous oxide by paramedics and AEMTs in New Hampshire and Vermont. You paramedics and you advanced EMTs, you need to know the protocols by heart. No excuses. UVA EMTs should also be familiar with the protocols and shouldn't hesitate to ask their partner if NitroNox should be used in a patient requiring pain control. I have to admit, sometimes I forget, and you jump starting my brain will make a lot of difference. So be a team player. Don't hesitate. Now folks, in the past, abuse of nitrous oxide by EMS providers has been a problem. Not at the UVA, but in general. Remember, nitrous oxide is a drug. And I have to say that any UVA employee who is suspected of abusing this drug will be immediately suspended pending an investigation. If found culpable, the individual will be terminated, law enforcement contacted, and a complaint against that individual will be filed with the state EMS agency. I have to have zero tolerance on this matter. Now, an accountability sheet will be put in the narcotics log that will be completed at least once every shift. The sheet will reflect what's on the truck, what truck that the unit is on that day. It should always go with the primary 911 truck. The security tag number should be logged in the appropriate box. I'm okay if you just want to use the last four numbers. And legible initials. If the unit is used and the tag is broken, it should be documented in the log sheet as seen on this slide, including noting whether a new tank was put on or not. If the alarm hasn't gone off, don't put on a new tank, just put it back into the case. And finally, apply a new tag and note the new tag number in the book. As I indicated earlier, the unit and the spare tanks must be left upright and not laying on their side. The photos indicate here where to put the unit in the ambulances. Spare canisters go under the bench seat. Empty canisters that have been used should be left outside the supply room. So in summary, NitroNox is a gas mixture containing 50% nitrous oxide and 50% oxygen. It's indicated for patients that are alert, cooperative, and complaining of severe pain. It's never administered by EMS personnel, only self-administered by the patient. It should not be given to patients with respiratory compromise or altered LOC. It may worsen conditions involving abnormal collections of air, such as a pneumothorax or a bowel obstruction. Side effects include dizziness, drowsiness, and occasionally some nausea and vomiting. And it's important that you remember to use it only in well-ventilated areas. The last thing to note, there is a competency sheet that every UVA staff member must complete and will be kept on file. Your educational program on NitroNox is not complete until that is successfully accomplished.